Sometimes someone comes in and, since their last visit, they've lost a few pounds and they say, in the last 4 weeks, I barely lost anything. And what gives? And I'm talking to them. I'm like, how's your exercise? And they're like, we're strength training. I'm doing a ton. And then I say, well, how are your clothes fitting? And they're like, well, it's looser.
Yeah.
Muscle weighs more than fat.
Yep.
And that's a perfect example of where the BMI fails, or where if you're staring at the scale, you're going to be like, what gives? But when you look at it, you are twice as muscular. Your clothes are all looser. It doesn't matter that your weight's not that different.
Yeah.
You've achieved the goal.
Yeah. Which is health, and you are healthier. So I love that. I want to welcome everybody back to a new episode of Beyond the Scale. Today, I'm very happy to introduce Dr. Aaron Sachs. He is one of our local bariatric surgeons. He is a delegate of the Association of DABS?
American Board of Surgery.
Okay. He's a delegate of the American Board of Surgery and a fellow of the American College of Surgeons. And more specifically, in reference to what we are going to discuss today, he's a fellow of the American Society for Metabolic and Bariatric Surgery. He specializes in many areas, but pertaining to what we're going to discuss today, he is an expert at minimally invasive surgeries, including weight loss and anti-reflux surgery. He performs flexible endoscopies, and he is also the director of the UVA Community Health Bariatric Program. So I want to welcome you and thank you so much for being here.
Thanks so much for having me, Dr. Minera. It's great to be here. I'm excited to talk about a lot of these topics, which are dear to our hearts and relevant to a lot of people.
Absolutely. And we started our conversation, pre-recording on how, you've been very gracious and always very, informative for us. We do non-surgical weight loss, of course. And I think that our specialties actually complement each other. And that's one of the main things you and I have always talked about, making sure that message gets out there, and that patients realize also that it's not an either or. It's another tool in the toolbox that patients have when it comes to helping them lose weight. So again, thanks for being here, and just for the the audience's information, give us a little introduction on what you do in the world of weight loss medicine.
Sure. So as you kindly mentioned in the introduction, I run one of our local weight loss surgery programs, but I am a general surgeon, boarded and trained. I did some extra training, also known as a fellowship, specifically in minimally invasive surgery, weight loss surgery, endoscopy. I also specialize in anti-reflux and hernia surgery, gallbladders, things like that. But one of my main focuses and main interests in practice is bariatric or weight loss surgery. And as you very astutely pointed out, there's no one size fits all treatment for anybody. And I think you and I are both eagerly awaiting maybe the day where there's a magic bullet or easy button. I don't know if that's ever going to come, but it's really nice that there's a lot of options that we can individualize for any given patient. My role is primarily surgical. And so when the patients meet criteria or are interested in or feel they could benefit from surgery, that's where I come in. And our program is very patient focused. We have some fantastic dietitians, some great staff, and our team goal is to help the patient get healthier. As much as I love doing surgery, if surgery is the answer, great. I love it. I'm on board. I'm going to do a great job. I'm going to do my best to help you. But my goal, again, is to help you get healthier. And even if we can help you in that regard, if the answer is not surgery or not surgery now, or that's still great. I think it's the goal is to help and get folks healthier.
I agree. And I think, that kind of prompts my opening question for you, which would be, I'm not sure. I think there also is a little bit of not misunderstanding, but maybe misinformation from a primary care doctor's standpoint. They're usually, as primary care doctors, we are the gatekeepers. patients come in and, we discuss their weight and say, hey, you got to lose weight, diet, exercise, all that. There are criteria, if you would mention that for us, where a patient should, or at least can start to consider the surgical option. For information for each individual patient out there, what would they be looking for in themselves to prompt the, hey, what, do you think I should see a surgeon or not? What are the key factors?
Sure. So, I could certainly launch into the specific surgical details and society recommendations, but in order to kind of keep it simple and, help everybody in terms of understanding, I think surgery should be considered really if your battle with your weight has been a problem or a challenge at all.
Mm-hmm.
And especially if you have some associated problems that your doctor has been worried about are related to your weight, or you're worried are related to your weight. For example, things like sleep apnea, arthritis, blood pressure, diabetes for sure. If you've tried all sorts of things before, if you've tried nothing before and you just want to learn, I think it's the time to ask the question.
Yeah. No, you mentioned something very important there. I think that it's always been an all or nothing proposal. In the past, it's like, I've tried everything. I've exhausted all possibilities. Now I'm at the point where I need surgery. That it's not a final step. It's not an end point. We start to kind of like we were talking about the analogy with diabetes and insulin.
Mm-hmm.
We start insulin earlier in the process. It's not until we've exhausted all possibilities. So I feel that surgery, patients should know that it's not an end all, because it does not take away, the onus of the patient to continue a certain pathway or a certain journey, even after surgery has been done. Not the curative,
sure.
Factor that maybe it was proposed to be before, right?
Yeah, and that's a great point, and unlike, for example, if I remove your gallbladder, it's out. The gallbladder is never going to bother you again. You are cured of gallbladder disease. Obesity is a disease, and unfortunately, it's a disease where there's no cure.
Yeah.
It's a lifetime battle. It can regress, it can come back, it can remiss. I like to think of the treatment options we have are ever evolving, and I kind of like to think of it as an analogy, just like you kind of do with the diabetes and starting insulin early. I like to think about it kind of like joint issues and joint replacement surgery, right? If you have joint problems, maybe it's minor and you might start with just some physical therapy. Maybe you might get a joint injection. It gets worse. Then you end up going to see an orthopedic surgeon and they try some other things. And ultimately you need a knee replacement. And then even if you get a knee replacement, you might need a revision down the line. Flip side is you might show up with an already destroyed knee, and surgery is going to be your answer from the get-go. But that doesn't mean physical therapy doesn't need to happen. That doesn't mean exercise doesn't need to happen. That doesn't mean you might not need injections. And I think similarly, the lifestyle changes, diet, exercise, all those sort of things, that's still the bedrock.
Mm-hmm.
And medication isn't going to work well if you're not also embracing the other changes and working on diet and exercise. Surgery is not going to work well similarly if you're not also using the other factors and interventions. And similarly, we're learning more every day, but we might actually have the best outcomes combining things. For example, medication before surgery to lose some weight and then get to a point where it's safer. Or after surgery, maybe the result's not as good as we think. Everybody responds to all the treatments differently. So using it after, I really think all these things are synergistic. And just because one might be an option doesn't mean it's the end or the conclusion.
Right. I like that. And I think, it's one of the things we're going to segue into, the synergy, the complementary use of medication combined, with surgery and different things like that. Again, looking at it not as an individual, type of treatment. We try this one, fails, we stop it, we try the next. It's more like you said, more a like multidisciplinary type of approach. So if a patient comes in, he sees you, she sees you, and they're like, okay, you know what? I want to have a little bit more information. You inform them. And we know at least some of the procedures that are being done currently: sleeve gastrectomy, gastric bypass, with, different variations of that. We talked about, prior use of gastric banding and even some of the endoscopic procedures, the balloons and things like that. So where are we with each of those procedures, and how do we, decide who gets what?
Yeah, it's a great question. It's one that we're trying to answer every day. And then new things come out and new ideas and new treatments and even new procedures. But sort of in the current state, I think some of the most common things that we talk about, you might have heard about the laparoscopic gastric band, which was a procedure done minimally invasive, meaning small cuts, where a plastic band or ring was placed around the top of the stomach. And one of the advantages of that is it was adjustable. You could put fluid in, you could take fluid out. That's essentially obsolete at this point. We take them out now. I don't really know of anyone who puts them in.
I remember a lot of complications from it too.
And it was a procedure that was fairly low risk, and it worked. But down the line, pretty much everybody ended up getting reflux, swallowing issues. Sometimes it would erode. Sometimes you get a port infection. Sometimes it would slip. And we pretty much don't put those in anymore. We do take them out. The most common procedures in the United States, particularly for weight loss, are the gastric sleeve and the gastric bypass. The gastric sleeve or sleeve gastrectomy is probably the most common procedure done in the United States, depending on the numbers you look at, usually 70%, 80%-ish sometimes. And this procedure, to simplify, basically is, again, minimally invasive, done laparoscopic or robotic, where we take the stomach, which is kind of like a bag type organ in the body, and sleeve it, right? That's why it's called the sleeve. Basically turn it into a small banana. And that procedure is very safe. It has the advantage of not rearranging anatomy. It keeps the continuity of the GI tract. It is permanent. That part of the stomach is gone. People who lose that, or people who undergo that procedure, on average, lose about 60% of their extra weight. So roughly speaking, that means if, say, your goal is to lose 100 pounds, a year later, on average, you'll be down 60.
Okay.
One of the Achilles heel of that procedure, particularly long-term, is it can cause acid reflux issues. So maybe it's not the best idea if you already have bad acid reflux or similar stomach issues. And, one of the things we do in our practice is a thorough preoperative evaluation for that type of issue. The gastric bypass is another common operation that is done today. And that procedure is a bit more complicated than the sleeve. Basically, we cut the top of the stomach and separate it off from the rest of the stomach, so creating a small pouch. So in that sense, it's similar to the sleeve in that we're making you have a smaller stomach. But beyond that, we then cut your intestines to reroute them to that small pouch and then reconnect everything down the line. So the bypass happens because the bulk of your stomach and the first part of your small intestine, while still connected to your digestive juices and pancreas, you have to do that, right, to survive, don't see food until later when mixing with the food that went through the pouch and the reconnected intestine. That procedure, compared to the sleeve, has some advantages and disadvantages. Advantages are because it's more of a rearrangement procedure. It actually has a bigger hormonal change. And I have a feeling we'll talk more about this, but believe it or not, the surgeries work more because of hormonal changes, not because of the small stomach effect. And that's an important thing to kind of remember. But the bypass compared to the sleeve has bigger hormonal changes. And so the bypass tends to be better at curing diabetes, tends to be better at curing high cholesterol, tends to be better at curing high blood pressure. They both can. The bypass is just a little better. Slightly more weight loss, slightly faster, especially in the first few years, about 70% extra compared to that 60%. Way better for acid reflux. You might be thinking to yourself, that sounds better than the sleeve. Why is the sleeve more popular? Well, you trade all that betterness for a more complicated anatomy. The complications are a little bit higher. It's still very safe, and there are more long-term implications. And part of my job as a surgeon is to help you figure out, if you're interested, which procedure fits you, right? And there are some things that might make sense from my standpoint. So again, for example, if you already have horrible reflux, I'm going to point you away from the sleeve. If your main reason to think about surgery is you're tired of your diabetes and you want help controlling it, bypass might be a better option. But a lot of the times when patients complete our program and have learned all about this, we turn to them and say, what do you think? You get to participate in that decision, because unless there's one of those strong medical indicators, it's really about your priorities, your goals, your worries, and what the future might hold. So again, I think it's very important that we approach every patient individually and what's best for them, and they get to take part in that discussion. And our goal is to help guide and bring a little medical knowledge too. Yeah.
No, that's great, because I was going to ask, the results, comparing the all the procedures. I think that, there has been a lot of literature recently showing that there is complete, reversal of metabolic dysfunction. And so I think that is one of the prime goals with doing the gastric bypass. Now, if a patient decides, hey, I want to have bypass versus, a sleeve gastrectomy, are there certain patients who would not be candidates for, mostly the need for follow-up or the need to comply, with certain behaviors after the surgery? Is there anything that would, completely, I would say, negate their candidacy for one or the other procedure?
Yeah. So there is and there isn't. And to further explain that, I think at the end of the day, right, and we've talked about this too, this is a disease where no matter what treatment you go with, it depends on the group.
Right.
You can't just have surgery and expect it to go like a light switch and you're good. You can't just take a GLP shot and expect, you're good. And so part of our surgical process is to, before you get to surgery, help figure out if this is for you. And there's only rare occasions where we kind of say no, right? There are certain things that are just not safe, right? Sometimes through no fault of your own, maybe a really bad heart issue and surgery in general is not safe. There are certain things that have the potential to get worse after surgery, such as alcohol addiction, drug addiction, and things like that. And so active drug use and things like that. Also, that's when we're going to say we can't do it. But even those things, and then the other things, emotional eating, binge eating, not being quite mentally ready, for example, if there's untreated depression or anxiety, these are all things that part of our program involves a psychological evaluation. And the goal is not to say no. The goal is to say, how do we get you there? Right. How do we get you ready? And some people might take longer than others. Some people might not be ready now, but later, as we figure things out. And so I think of it much less like, there's these criteria where you can't have it,
right,
beyond the pure safety type surgical issues, and more, okay, how can we help you get there?
Yeah. And I think you highlight something that's really important, especially in my world, in the non-surgical, is ensuring that, there's that ongoing support. There's unfortunately a lot of times patients, will fall out of the program 2-3 years down the road, and these issues require long-term management for sure. So that highlights obviously the need for that multidisciplinary approach. Segueing into my next question. So obviously it requires a lot of people involved. If a patient comes to me and says, Dr. Minera, I'm considering, maybe surgery, what should my patient be looking for in a program that is going to provide them the best possibility for success in the long term? So, that's pretty much the programs that we have here. But so patients understand, what should they be looking for? Because there are a lot of places that offer you, hey, I know a lot of my patients, unfortunately, will sometimes also go to different countries and get it done. And that's not ideal, because it's not just about the procedure. It's like, okay, now what do I do? Where's my team?
Yeah.
So
I would argue the most important thing of course I have to do a good job, right? And technically, as a surgeon, I work very hard to do that. We all do, right? But more important to your long-term success is that long-term follow-up.
Yeah.
And so I discourage folks from doing kind of the shortcuts, right? If you're doing the shortcuts, you're not going to do well long-term. But in terms of what to look for in a program, there's a lot of good doctors out there. There's a lot of good surgeons out there. Generally, you want to make sure that your program has board certified surgeons, ideally ASMBS verified surgeons or fellows of that society, or who have completed the fellowship and that extra training, because it is more detail and a little more complex at times, and different than standard general surgery. Often programs are accredited by the ASMBS as well. I think the single most important non-paper credential 5-star on Google thing that you can quickly find is organization, right? For all these things we talked about, right? If you get to a program and you leave super confused on what your next steps, or if you do leave confused, you call it figure it out and you can't figure it out and no one's able to guide you through it. And if it's not, I think, organized plan of attack is how this succeeds. And I think that's one of the non-tangibles. And, of course, you get a sense when you meet anybody in any professional capacity, do you jive with them? It's not all roses and flowers either, right? Unfortunately, with what we do, sometimes bad things happen, sometimes complications happen. And it's just as important to be there for the patient when that happens. And that's the kind of thing you want to find in your doctor.
It's a long-term relationship. Definitely you're in it for the long haul, and you want to make sure that where you're going is not going to be a, fly by night type of situation. So that's great. And I agree. I think that for our audience, it's very, very important that there is, credentials backing a established program, and ask all the right questions. I think that's key. So we found the program. We've undergone the surgery. Things have gone well. Which complications are the most common ones that you see after surgery, and then beyond the short term, why or how do some of these quote unquote fail, and what do you do for your patients?
Yeah.
So I know it's multiple questions.
Sure. So we'll start with the complications first. Short term, as you know, every surgery has potential complications, and I'm not going to do what those drug commercials do here and blah, 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 and list every possible thing. 95% of the time, 99% of the time, none of that's ever going to happen.
Yeah.
But things like bleeding, heart attacks, et cetera, are all possible short-term complications. One of the things we do really well, I think, at our program is help make sure that everyone is medically optimized and we're minimizing any risk and trying to make it so those things don't happen. In the short term, right after surgery, there's obviously a very specific diet we do. Your stomach is completely different. Some folks have trouble with hydration or some nausea and vomiting and stuff at the beginning, or fatigue. And a lot of that is fairly common to at least differing degrees in patients. That, to me, is not so much a complication as what is almost expected.
An expectation, yeah.
But it kind of overlaps with that. The major scary complications at the beginning tend to be things like leaks and strictures. And, anytime we do surgery where we're cutting the stomach or reconnecting things, obviously I'm not going to leave the operating room if you have a gaping hole in your stomach. That would make me a bad surgeon, right? But sometimes, despite the best of efforts, maybe the blood supply is not as good as we think. Maybe you get a freak GI bug 3 days later and violently vomit and tear a stitch, or one of the reasons we try to avoid any nicotine, for example, is it decreases the wound healing, increases the risk for that kind of thing. You get what's called a leak. Leaks can be life-threatening. The good news about a leak is we catch it, we get you through it, but it stinks. It's often months of recovery. Stricture is basically where one of the new connections we have, where the stomach after the sleeve is maybe a little too thin. And you can imagine maybe eating doesn't go as well when that happens. That tends to be endoscopically treatable with endoscopy and stretching and things like that. Rarely people need to go on IV nutrition or feeding tubes. That's typically when the really bad things happen. But, as surgeons, we wouldn't do surgery if really bad things happen frequently.
Right.
So fortunately, these are rare. The more common stuff tends to be more long-term. And when you have weight loss surgery, one of the things we recommend is a multivitamin for life because you're vulnerable for certain nutrition deficiencies, for example, iron deficiencies, vitamin B1 deficiency, things like that. Good news is, with the sleeve in particular, if you're good with your vitamin, you are probably not going to get into that trouble with a bypass and some of the other more complicated operations. Sometimes you can be perfect with your vitamins and still get into trouble. The good news about that is it's all treatable. You just have to be on top of it.
Right.
It's one of the other reasons we like to see our patients every year to check in. People tend, it's very rare where someone loses too much weight, right? In other words, typically these procedures done correctly and well are not going to cause malnutrition unless there's a concurrent complication. And that's when we as surgeons have to be like, hey, what's going on here? Long term, we talked a little bit about sleeves and reflux. That's something that can crop up. Bypass has a couple other unique things. There's a special ulcer you got to watch out for, often triggered by smoking or NSAID medication use. And also the rearrangement of the intestine can make you vulnerable to a certain bowel blockage. And again, all these things aren't common, but can happen. And so you got to be aware of them. And I, as your surgeon, help watch for them.
Right.
I would say the most common complication, and I quote this, is weight recurrence or weight regain.
Right.
And
what people commonly would say failed.
And I like to shy away from the word failure.
Absolutely.
Because typically, even in those cases, and 10 to 20% of people after weight loss surgery will regain some weight, right? You compare that to 95% of people who are just using diet and exercise, and depending on the study, 60 to 80% of people, depending on the medication and stuff, after a number of years. But it's not zero because we have no magical bullet treatment, right? But a lot of the times, even if that happens, if you look back, you're still down 80 pounds from where you started. You're still off your blood pressure pills or less blood pressure pills, less diabetes pills. To me, that's still not a failure at all.
Absolutely
You increased your life expectancy. You bettered your comorbidities. But the disease isn't going away. And that's when we want to attack again. Look at adjunctive therapy. Have we tried medication? Let's throw in medication. Let's revisit some dietary things. We do consider revisions at times. It is very rare that you have someone who has the surgery and like minimally responds at all.
Right.
But, one of the things that we know about medicine is every single person's different. Everyone's genetics are different. Everyone's metabolism is different. Everybody's response to therapy is different. And when we talk about things like, on average, after sleeve, you'll lose 60% of the extra weight, AKA be down 60 pounds if you're 100 pounds overweight. That's the median, right? So half of people aren't going to quite get down 60 pounds.
Right.
Half will get more. A lot of that can depend on your buy-in with the lifestyle changes, the exercise, diet, avoiding snacking, grazing, and establishing healthy habits. But the whole idea is about helping you get healthier. And so I tend not to focus so much on the scale, but hey, where were you when you started? Where are you now? Are you less tired? Do your joints hurt less? How's your diabetes doing? Right? And if those things are improved, you haven't failed. And even if some of the stuff is coming back, you being there and wanting to take charge, again, you haven't failed.
Right.
Sometimes the surgery long-term, there's some rare complications. The stomach is built to stretch, right? Of course. And the hormonal effect is more important than that.
Right.
And sometimes we find things that we can surgically correct, but it's more property of the disease we're battling.
Yeah. And I love that because I think we share the same philosophy or the same vision, that it's not, it's you always derive benefits, from where you started and where you are, you're a step ahead. Better quality of life. And the other factor also that, is inevitable in life is there are different challenges at different times in your life as well. So it's not like, where you started today and where you had surgery, you may have new challenges in the future where it will influence, your weight gain or loss, or, even access maybe to services. So yeah, I fully agree with that. And I love the fact that you don't call it a failure, because I think a lot of people will, it's a number on the scale. We talked about this. We talked about BMIs, and how BMI is, in my opinion, much better for population studies. But once the patient comes in, we're looking at body composition. So if the body composition is better, the metabolic profiles are better. The weight, it's it's one of the objective ways that we can gauge whether procedure helped or didn't, or the medication is helping or not. But at the end of the day, it's much more complicated than that.
And one of the cool things about that I love to see when it happens with my patients are, sometimes someone comes in and, since their last visit, they've lost a few pounds, and they say, in the last 4 weeks, I've barely lost anything. And what gives? And I'm talking to them. I'm like, how's your exercise? And they're like, we're strength training. I'm doing a ton. And then I say, well, how are your clothes fitting? And they're like, well, it's looser.
Yeah.
Muscle weighs more than fat.
Yep.
And that's a perfect example of where the BMI fails, or where if you're staring at the scale, you're going to be like, what gives? But when you look at it, you are twice as muscular. Your clothes are all looser. Doesn't matter that your weight's not that different.
Yeah.
You've achieved the goal.
Yeah, which is health, and you are healthier. So I love that. Okay, so a hot topic, and I think this is kind of like where I wanted to, really have a good discussion is, where are we in, so when somebody looks at a non-surgical weight loss doctor and a bariatric surgeon, for some reason, I think we're competing. There's no competition. It's just complementary, and we should be working together. And so there are a lot of studies. Also, I think recently I saw in the Obesity Society journal where there was a study about bariatric surgery, metabolic surgery, and the complementary use of GLP-1s. If you could comment to that'd be great, because I know there are a lot of patients that I have in my practice who've had surgery and are also benefiting from the use of a GLP-1. Where do you see that? What does the future look like for us? Is it going to become, standard of care to utilize them? You had alluded to it, a little bit prior, but what's the data, or what's
so
showing?
It's a hot topic, and I was just at our ASMBS meeting in San Antonio a few weeks ago, and that was, I would say, the topic du jour, and the Mason lecture, which is the named main lecture of the conference, was an awesome one by an endocrinologist, and this was the very topic. Especially, I feel like, and I'm sure you'll agree with me here, you have, I think, more experience with this particular thing, but before the GLPs came out, we had some weight loss drugs. They kind of were meh. Sometimes they worked. It could achieve maybe 5% weight loss, something like that. There were a lot of side effects. And it kind of was a little bit like surgery was a last ditch effort, right? Because there wasn't a lot. We had a big treatment gap. And I think the GLPs, and as we continue to develop more things, are great, because now we have a medication that works, and works well, and can lower cardiac risk and all sorts of good things. And depending on the study you read, folks on the medication, the weight loss can approach that of some of the surgical interventions, which makes the treatment much more like a spectrum. And again, we talk about not one size fitting all, and a synergy. And we're continuing to learn more about this every day. In my practice, we've started to use the medications preoperatively. While we don't per se require a certain amount of weight loss before surgery, sometimes due to various reasons, we do want some. And any weight loss before surgery makes surgery easier for me. Easier for me means less complications for you. Right. We know that everyone responds a bit differently, right? Some patients are going to have surgery, and even if they're doing everything right, they're not losing as much weight as we hope. And so we'll pull the trigger on adding the medication post-operatively, and maybe we're going to talk about it for maintenance. And you have some folks who, unfortunately, the disease has kind of gotten completely out of control, and you're talking about the super high BMI folks, and you've got to get creative on strategies and maybe a staged approach, maybe the simple operation with some medicine. And then when they lose some weight, you convert them to a bypass or a duodenal switch or something, and then really get to the good targets. And I think it really mixes well, and it's definitely not an either or. And if you're thinking about surgery, that doesn't mean don't explore the medication options as you're looking at the surgical option. Finding what will work well for you is what's most important in the moment and for the future.
Yeah, you brought up a good point there. I had a podcast before with Dr. James Ward, orthopedic surgeon, and one of the main reasons, that at least in the orthopedic world, that they will refer for weight management is because it does, we would say, like, maximize the idealness of that candidate to undergo surgery. So even from a health and a complication and even survival preoperative status, it helps the patient do better, right? During the surgical procedure. So using it to maximize a patient, then getting the surgery, and then continuing it, I think is also a very important factor. And like you're saying, I mean, both metabolic surgery and the GLP-1s are showing that metabolic correction. And I think that that's really where the message is going for a lot of, our patients, is that, I tell them all the time, you walk in the door and you want to lose weight. Once I capture you, I want to maximize your metabolic health, because that in the end is really what's going to, provide you the quality of care. So, or the quality of life. So yeah, I like that. Is it something that are you getting a lot of pushback from your patients? When they come in and they're like, well, I want surgery. I don't want to be on this medicine. One of the reasons I want to have surgery is because I don't want to be medicated the rest of my life. How do you approach that? Because that's one of the main questions I get with my patients is, hey, okay, comments is, I'm willing to go on this to jumpstart me. But then afterwards, I want to make sure that I can sustain this without the medicine. I'm very cautious about how I approach it, because I don't want to be perceived as somebody who is going to make somebody dependent on a medicine. But at the end of the day, my focus is to make you healthy, and it may require long-term intervention. So do you approach that?
It's a great question, because I do see some patients who come because they don't want to be on medication. And I think that's a perfectly reasonable goal and a reason to look at surgery. But again, talking about this whole conversation we had, long-term, depending on how the disease process is in that particular patient and them fully embracing the lifestyle changes that go along with the surgery, I can't say 100% of the time you're never going to need a medication again. But it is a valid reason to look at surgery, and it can make that possible. So it's again individualized to each patient. And I found that the patients we have, if their weight is such where I think some preoperative weight loss is a good idea, they embrace that too. They just want to get healthier. And I think that's everyone's goal here.
Absolutely. What are predictors, with your experience and the multiple surgeries you've done, and, the cases where you see long-term success? What candidate or what characteristics predict long-term benefits from surgery?
Yeah, so it's a great question. I think if someone has a high metabolic disease burden, they tend to do well with surgery. And again, not necessarily talking about the weight, talking about helping potentially cure some of those diseases.
And in your practice, you see, so diabetes.
Yeah, so diabetes, for example, diabetes is a good one. I have had a fair number of patients, for example, who we do the weight loss surgery on. The day after surgery, they're done with their diabetes meds. They haven't lost a pound yet.
It's amazing.
It's really cool. That's one of the reasons that we figured out that these surgeries are truly metabolic surgeries. And it's
Mhm.
not just about, oh, you're not absorbing as much or your stomach is small. That's a hormonal change.
Yeah. Yeah.
So I think those folks tend to do well. And folks who really embrace the program, embrace the work that goes into it, those folks always do well too.
Mhm.
And then the ones who come back, right? Because if you're maintaining, you want to keep the disease at bay as long as you can. And for the inevitable, you suddenly had twins and you can't exercise because you're too tired and the
Yep.
babies are screaming, or
Yeah.
unfortunately a death in the family, something like that, and things start to slide backwards. That's going to happen. And so um, you get into trouble if that percolates and you're not following up.
Yeah. I think that's a key component right there is the follow up and the follow through. There is, and it's a double edged sword. I think when I mentioned this to some of my patients is it's a chronic condition and it requires chronic attention. It's like us as physicians, right? We don't graduate med school and stop reading
Right.
or stop learning, right? I mean, it's an ongoing type of process, it's ongoing education. I think if patients embrace it that way, after you've had surgery, it's not over. Your yearly follow-ups. I'm floored by the amount of patients who come in and see me who have had gastric bypass and have stopped taking their vitamins. And it's like, well, why aren't you taking them? Well, because I just didn't go back and I just, I got busy and no, I mean this is an ongoing thing and you have to pay attention because things change and it's not failure like we're mentioning right now and there should be no shame in continuing to seek out that accountability. I mean this is what we're here for. Your team is here to help you succeed. It's not a show of weakness. It's a necessity to make sure that you're constantly uh checking in, right? So
Absolutely. Absolutely.
that's key as well. And I think that mind shift has to happen, which is so hard because again, I mean, we talk about the stigma of being overweight and obesity and all that, and I think my patients are their own worst and critics when it comes to it. So
Yeah.
yeah, so I mean, this is, and there's so much more that we could talk about. I did want to touch on one last thing. We kind of, mentioned it, and I'm not sure what the data shows or what the research shows. If we are modifying a patient's anatomy, obviously, we're shifting a few things here and there, and we know that GLP-1s work on a hormonal basis, so we already determined that. But if it's slowing down gastric emptying, and we are obviously changing the gastric anatomy or the amount of your stomach, intestine, whatever we have there been any types of correlations with the use of GLP-1s and other things that we need to be looking for with patients who've had gastric bypass, or is it too early yet in
I
that
think it's
game?
probably too early to tell, but one of the things after a gastric bypass, in particular, because we're rearranging the intestines, you're more vulnerable to certain bowel issues. And I think any medication that changes GI motility is probably going to be felt more likely in terms of side effects.
Mhm,
I think that
mhm.
makes sense to me.
Yeah.
And the other thing too that if you or I are on one of these medications and our stomach's not emptying as well, we're going to burp, we're going to get some reflux, we're going to vomit, we're going to do more of that stuff, which will relieve the symptoms. If you've had a gastric bypass, the bulk of your stomach can't do that.
Mhm.
And so it might increase the discomfort for those reasons.
Yeah. Um, we mentioned at the very beginning, and this it kind of made me think right now while you're saying it. One of your areas of expertise is the flexible endoscopy and actually addressing these reflux issues, what we call Barrett's esophagus and
Mhm.
all that. Do you anticipate maybe with especially like sleeve gastrectomy patients and the use of GLP-1s, the probability of actually this increasing the need for this type of procedure and maybe some more esophageal pathology.
Yeah,
I don't know.
it's definitely possible. And I mean, sleeves in of themselves are thought to be refluxogenic. And there's a lot of controversy in this area of the literature. Roughly, if you have a sleeve, the way I think about it is a third of the time, if you have reflux, it's going to get better because you lose weight. A third of the time, nothing's going to happen. A third of the time, it's going to get worse. One of the things that we do know is that um, the risk of Barrett's esophagus de novo, which is a precancer of the esophagus arising out of nowhere, is higher after a sleeve. And so it's a relative contraindication to doing it. And so if there's a background of reflux issues, perhaps susceptibility to stomach emptying issues, that might be something to consider. Paradoxically, a sleeve actually increases gastric emptying, even though it worsens the reflux stuff. Gastric bypass, on the other hand, tends to be curative of acid reflux, but sometimes if the intestines aren't working as well or the motility is slowed, you get reflux, which is not so much an acid reflux, it's just stuff backing up.
Right.
So it's interesting. And then in the world before surgery, right, I do anti-reflux surgery as well, and I see some patients sometimes just because they're tired of their antacid and wondering what they can do. And actually, the gastric bypass is the best anti-reflux operation we have. And so if someone has bad reflux, especially if they're overweight, that's a reason to think about it. And sometimes I'll have a patient come in with horrible reflux and I'm like, are you on any of the GLPs? And they're like, yeah, I started 6 months ago. When did your reflux start? 6 months ago.
Mm-hmm. Yeah.
Well,
right.
Then you kind of get into a point where, again, this is why this is so individualized, right? Do you stay on the meds because you've had a good weight result, but you're miserable with your reflux? Do you stop the meds, risk gaining the weight, but you no longer have reflux? Do you consider surgery at this point because of that battle, right? And these are the types of people that we help figure out what to do with and where they go.
And that's great. I mean, I think this is wonderful. I mean, I'm really glad we were finally able to coordinate, get together and talk, because I think there are a lot of patients out there who have all these questions and really don't know, where to go or who to advocate with. And so if I have patients out there, and I'm pretty sure there are a lot of them out there, and they want to talk about these topics, what's the best way? For in your program, and of course, just to remind people, Dr. Aaron Sachs is the director of the UVA Community Health Bariatric Program. Do they call, your office? Do they look up? I mean, is there a special, number or something? Do they have the conversation with their primary care doctors and they send them? If people want to have further discussions, what's the best means to get
The
around?
answer is yes.
Okay, perfect.
All those things.
I love it.
We welcome. If you walk off the street, honestly, I probably can find a way to see you that day.
Yeah.
And so you can call. I have great office staff. We have a great patient navigator coordinator, great dietitians. You can have your regular doctors send the folks my way. You can Google us and send a message that way. And at the end of the day, like I said, right, my goal is to help you get healthier. And just because you come in for a consult doesn't mean I'm going to grab your arm and rip you over to the OR, right? That's your opportunity to learn some of the basics. And even if you're not sure if surgery is for you, working with our program can be very helpful. You're going to see the dietitians. You're going to have that psychologic evaluation. You can look into the possibility of weight loss medication. You can go see Dr. Minera, right? These are all things that don't exclude each other.
Mm-hmm.
And if you end up deciding surgery is your answer, we'll help you with that too.
Yeah. And I think the last message also I'd like to give, for the audience, especially if you've had any type of surgical procedure for weight loss, a lot of times, it's having a conversation with somebody like Dr. Sachs is important because there are certain follow-ups that need to be taken care of. Some people need to have, their like a routine endoscopy. I mean, things have to be looked at. So remember to address it, whether, you go back to your surgeon, if you're in a different area and you don't have access to your original, bariatric surgeon. Dr. Sachs, again, expertise not only in the surgical, the weight loss surgical procedure, but also in his passion for the flexible endoscopy is something that I think is a must and it's a given. So I encourage everybody to take care of their health, just like we would, get a colonoscopy,
Yep.
just like, when we spoke to Dr. DeCastro, men get their PSA checked. I mean, you've had surgery, get your GI tract checked out. And so I want to thank you so much for being here. I think this is going to be incredibly invaluable, and I have a feeling that we're going to get requests to do this again. So
Well,
thank you
this
so
this was
much.
great. Thanks for having me, and happy to come anytime, and happy to chat with really anybody about this. I
Appreciate it.
mean, I think you and I both are passionate about what we do, and really helping people is a big driver.
Absolutely. Again, thank you so much, and look forward to doing this again.
Likewise.
Have a great day. Thank you.